Well, you are most welcome to this video, and a welcome back to Professor Robert Clancy from Sydney, Australia. Professor, always great to have you. Thank you for coming back.
It's as always a great pleasure, John.
And you've just been to the official book launch of COVID Through Our Eyes, which is the experience of groups of people as they've gone through the pandemic. And you've been there since the start, Robert, and I believe you gave a keynote address at that book launch.
Well, I gave a presentation more as a sort of review of what's happened through the COVID experience and essentially what lessons we've learned as a result of it.
Yep. And should we look at your slides, Robert? In fact, that's quite a good medium,
these
I
are
think.
the slides of the presentation I gave.
Yeah.
The garish colour, I felt that I'd be putting people to sleep, John, and so I thought if I had these bizarre colours that it would keep them awake.
I'm sure you certainly don't put people to sleep, Robert. They might doze off during my bits, but
I doubt it.
Right. Well, I mean, a general question first of all. Before we get on to the detail, are the authorities learning? Are the powers that be evolving and changing, do you think?
Well, I think that's a great tragedy that we're not learning, which is out of sync with every pandemic, certainly in Australia that we've had. It's been a learning experience and we've benefited in the sense that we've gone forward. But as you'll see through this presentation, we seem to have stagnated somewhat and perhaps gone backwards.
Obtuse is a good word, Robert, isn't it?
It covers a lot of sins.
A deliberate refusal to learn. Anyway, let's not start ranting as we could do. Let's go on to your Let's go on to your first point. How good are genetic vaccines?
Well, I think this is just an introductory slide, and it identifies the 5 issues that I wanted to talk about. The first was how good are genetic vaccines. The second was how dangerous are genetic vaccines. And then the third, which I think is a very important one, is what is the most effective therapy for COVID. The fourth, I specifically am interested in the post-COVID vaccination syndrome because, as you'll see from these slides, this is one of the best-kept secrets. I see it very much as the COVID legacy. It is what society's been left as a result of our interventions. And finally, I thought we should look at where we're going and what we haven't learned and the mistakes that we really need to address for the future.
Sounds interesting and very beneficial for individuals and for society as a whole.
Right, well, this is the first topic, and that is how good are genetic COVID vaccines. And the main points that I wanted to make with this slide was that any vaccine which is injected to prevent or modify the outcome of an inhaled pathogen, a virus or a nasty bacteria, has to fit in with the biology of the whole system. It has to understand and work with the rules of mucosal immunology. And what we know from those, and we've known that from 80 years of working with flu vaccines, is that an injected vaccine will not prevent the infection being established in the body. It will not prevent transmission of that infection to other people. It will not develop herd immunity. Now, we all remember those early years, or certainly in my country. Every night on television, we'd have these so-called experts telling us that, well, you know, we're going to have mandates, we have to have lockdowns because we need to prevent you getting infected, prevent you transmitting the infection, and, you know, we're going to move towards herd immunity. None of those were ever possible, and of course they were never attained because of the biology of the problem. And so what they do, what a vaccine does is that it puts a wall up between the airway and the rest of the body. And so it prevents the movement of the nasty virus, the pathogen, into getting out of the airway into the lungs proper, where the oxygen is taken up and the carbon dioxide is delivered out. And so that represents more severe disease. So what we would expect for any injected reasonable vaccine is that does that. It may not prevent infection or its transmission, but it should dull the severity of the infection, and we used to monitor that by admission to hospital or death. And indeed, early on, the genetic vaccines did prevent reasonably effectively severe disease for a short time. And that was the last point on number one, and that is that with any of these protective efforts from an injected vaccine, because of the profound suppression of any type of immune response that's activated in the airways, turning it off, the protection is going to be for a relatively short time, maybe 6 months, but certainly not like a tetanus vaccine or a measles vaccine lasting maybe 10, 15 or 20 years. Now, the second point from this slide, John, is that the messenger RNA vaccines in particular were very different to anything we had ever done before. There was never ever given a reason why we didn't use a traditional vaccine. There was never ever any evidence that the messenger RNA vaccine was as good as a ground up virus, the old fashioned type of virus, which of course we know about. We know the safety issues, we know the efficiency issues, and we know the cost. And this was very, very important. And it's quite interesting that the only study I've actually seen was a recent Korean study in young boys where they compared as a booster an antigen vaccine with a messenger RNA vaccine. And guess what? The antigen vaccine was more protective than the messenger RNA vaccine. So even at this level, we now have some data showing that there's no ongoing advantages of using these genetic vaccines.
And this is just a huge mystery, isn't it? Why on earth did they go for that genetic RNA route? There's just...
Well, someone made a lot of money.
Yeah, there's no question someone made a lot of money, but I've never heard any scientific explanation as to why that was. That decision processing is decision making is just a complete black box, isn't it? And it's just bizarre.
I think that's the point. And we're still in the position where now there are many people, certainly here, that want to take over and completely transform our vaccines into not just the messenger RNA, but the self-replicating. It just goes on and on. And yet we haven't sorted out the red flags from the first round, let alone shown they're any better, which they're clearly not.
Incredible, and thanks for that really concise explanation, Robert. That makes a lot of sense. I think it really summarises what we've learnt over there.
Point that I didn't mention from this slide, John, is that when you inject an antigen vaccine, that is, you grind up the virus and you just inject it to get protection, you have a very precise small amount of antigen, and it stays where you inject it. When you take a messenger RNA, you're not actually injecting the antigen, you're injecting a genetic message that goes, and I think this surprised them, it goes throughout the body and potentially infects every cell in the body. Yeah. So that every cell becomes a factory. So the amount of
potential factory, yeah, absolutely.
Exactly. And so the antigen is produced in completely uncontrolled amounts. And as we'll develop the ideas, not controlling the amount of antigen has consequences.
Yep. So there's a fundamental axiom in healthcare when you're giving medicines, of course, give the right dose of the right drug to the right patient via the right route at the right time. And we can't fulfill that because we can't give the right dose because we don't know what dose we're going to get.
Well, absolutely. And the first, if you in Immunology 101, I think a couple of years ago we looked at this, John. You draw a curve where you get increasing antigen, you get increasing response, and on both ends, small amounts, large amounts of antigen, you get negative immunity. You turn off the immune response. It's the first principle.
Yeah.
And and I've not seen anybody talk about this in terms of the COVID vaccine saga.
No, and this was all completely clear to you, Robert.
Well, it should have been clear to anyone who calls
Yeah.
themselves an immunologist.
Yeah. Now you've explained it all. It's such basic science, actually. It's completely intelligible and yet ignored by regulatory bodies and senior scientists around the world. It's the word I keep coming to is bizarre, inexplicable. It's I think everyone senses the frustration.
Thinking, John, that they must have known this. They must have known this, and they thought they'd get away with it. But of course, as time's gone, and you'll see in some of these subsequent slides, the downside of this false way of thinking and the terrible mistakes that they made.
Yep. Okay, so that was that slide. COVID vaccines in 2025.
Right. Now, this, I think, is one of the most important slides. All these slides are based on published data. They maybe not be published in the Lancet or the New England Medical Journal for fairly obvious reasons, but they're serious databases. Now, I think this is probably one of the most important slides that everyone should look at. So we'll go through this fairly slowly.
Yeah.
What we're looking at here is COVID vaccination study done by a very good group in Quebec in Canada. Now, I think they're the best around. What they've done is, right from the rollout of the vaccine in early 2021, they've been following each vaccine and each booster that's come out and looked at the protection. Now, if you look carefully at the vertical numbers there, you'll see there's a line which is 0.
Yep.
You can see that 0 line. Now, above that, we're looking at protection as a result of the vaccination. Below that line, you're looking at not just no effect, you're looking at the reverse of protection, which is promotion of the problem.
Predisposition to that particular infection.
Yes. What you're looking at here is in people in Quebec, or the whole Quebec province, over the age of 60, and protection against going into hospital as a result of COVID infection. And it applies to what's called the XBB booster. This was the booster they were using in 2023, 2024. It's the one before the current booster. And it's one of the, it was a booster that, with all the boosters, was always out of sync with what was actually happening in the community. In other words, the virus, the COVID virus in the community infecting people had moved on. It had changed genetically.
It's a rapid evolver.
Yeah. So what we're looking at here is 10 months of a 12-month vaccine cycle. So if you're going to bring in a new booster every 12 months, we're looking at 10 months of that, just the 10 months. Now, if you look at the blue squares at the top, they reflect what the prevalent virus in the community was at the time. And the light blue, which dominates on the left, is the XBB. In other words, it's well matched against the immunising vaccine virus, which is XBB. But as you can see within, and this is, you can see months 1, 2, 3, 4, they're all months. By month 2, the XBB is completely gone. And it's replaced by what's called JN1, which was we'll call it, number 2 has come along.
Yeah.
Now, if you watch that, by the time you get to the 6th month, there's basically hardly any of the JN1, and you've got the so-called KP variants. You've got the third of these. So here within 6 months, you've moved not one but 2 variants from the one that you're being injected with. Now, there are 2 variables that this slide shows. This is looking at protection well down into 2023, 2024. It's looking at a booster 3 years after we started the vaccine program. Now, if you look at the amount of protection you're getting at the beginning of, after say 1 month.
This is from protection from hospitalisation.
protection, absolutely, against going into hospital if you got COVID and if you're over the age of 60 and you live in the Quebec province, of which obviously you can see the numbers right at the top. There's quite a few people involved. So here we've got 50%. And you might say, well, that's half the people are protected from going into hospital. But remember, when the Quebec group did their studies back in 2021, with the first rollout, they were getting over 80% protection, lasting at least 6 months. We've come a long way from that. Now we're getting protection. Now, if you go along and look at, say, 3 months, that protection is down to zero. That protection is down to zero. Now, from there on, for the rest of the cycle, the protection you're getting as the different variants keep coming to play, you're running around zero. And what's very important is to look at those vertical lines, which are the confidence intervals. And they're basically 95% of the population fit between those lines. And as you can see, that from 3 months after the vaccine, a substantial number of people are getting a promotion of outcome of the infection, more hospitalisation than the group that was not vaccinated. So you're comparing this with the unvaccinated group. So from 3 months on, you're getting either very little protection, no protection, or negative protection. In other words, you're actually getting more admissions to hospital. You're getting worse, more severe COVID infections. Now, this is exactly what's happening now with the current one. And people are being given the message to go along and have the next vaccine, but they should be presented with this data so they can make their own mind up. Now, do you want to have even more suppression? Because the more vaccines you get, the reason it's 50% and not 80 or 90% is because they've had 3 or 4 vaccines before, plus perhaps 1 or 2 infections with COVID. And you're getting this loading of antigen, which is turning off the immune response and making you more prone to infection. So John,
there's a recognised. You reckon there's a recognised mechanism that predisposes people to infection with repeated antigen exposure, is there?
Yes. What's happening? It's the yin yang of mucosal immunology that you stimulate, you get positive and you get negative. And the more you stimulate, you get more negative. And it's all to protect the body against uncontrolled. For example, if you had a positive immune response against the millions of bugs that are sitting on your airway, you'd blow up like a hand grenade. So you've got to have a suppression to stop that hand grenade blowing up the lungs. But of course, it's a bit artificial when you come along with a messenger RNA vaccine because this is, you're actually playing the biology game. You're not playing the artificial immunology game.
It makes sense. We're exposed to this repeatedly. So the body thinks, this is just routine. I won't bother responding to it, and it actually.
This is not isolated information. The group there's a group in America that's been doing finding exactly the same pattern of results. The more they have of the booster, the more they're getting the suppression and more infections.
That's the Cleveland Clinic data, I think, isn't it?
Cleveland Clinic. Very good group, very decent people. I've been communicating with them, and I'm really very fond of the guy there because he's an infectious disease physician, and he actually thanked me for pointing out he couldn't understand why they were getting the greater number of infections, and it's clearly because of the profound suppression. The same group last year have just looked at the influenza vaccine in this 30,000 group that worked for the Cleveland Clinic, and there was a 27% increase in infections in those who were given the vaccine. 27% increase in number of infections in the vaccinated group. That is scary because that is innocent bystander suppression, not just against the COVID, but presumably, in my view would be, that it's likely that this is a population given COVID vaccine after COVID vaccine, and the suppressor cells have mounted to such a degree that they're actually turning off the amount of immune response.
Oh, really?
Yeah.
So cross immune suppression.
Cross immune suppression, and you'll see this in a cancer slide I'm putting up a little later. This is very serious stuff.
Well, it really is. I want as much immunity as I can get, Robert, because at my age, cancer's become much more likely.
And you're half my age, John. You're 21, aren't you?
Yeah. But no, I mean, Gus showed us this. Gus Dalglish, the oncologist, you know, the way that immunity drops off.
That's right.
And there's like a mirror reciprocal line of increasing cancers with increasing age. It's
65 seems to be the line, and I'm nearly there, so I've only got a few more years.
Yeah, but all of us need all the good immunity we can get, and anything that messes that up is a really bad idea.
But I want people to really look at that slide. Will you be able to put some of these up, John?
Oh, 100%, yes. I'll put that up in
this is so important in understanding and interpreting the stuff we're told by the people on TV.
Yeah. No, we'll put that on as a big picture. People to better see that clearly.
No, but this is in the public. All this information is on the public record. It's just that not many people want to talk about it.
Yeah, and mainstream media like the ABC and BBC probably haven't got round to it yet. Maybe it'll be on there. Maybe it'll be on there tomorrow.
Well, it's a pretty foreign language. It's called immunology. You know.
But fortunately, we have translators such as yourself available. You know?
I don't know about that.
You know, why does the country go to all the bother of training up physicians and immunologists just to ignore them? You know,
it's so sad, isn't it? You know what we're seeing, I think, in the legacy press, be it press or TV or radio, with obvious exceptions, but we're seeing they're no longer basically
public servants.
They're all commentators. Be the age of 19 or 20, they're experts on everything.
Yeah, absolutely.
It's created so much problem.
Well, I've cancelled my BBC television licence. Sadly, in Australia, you don't have the option to cancel the ABC.
No, you have to pay, don't you? Actually, we quite like the music. They do play good music.
Okay, yeah, music's unambiguous.
Only when they open their mouths that it becomes a problem.
Yeah. Just tell us what is the genetic? What do you mean by genetic vaccine, Robert? First of all,
they're not really. A vaccine really is part of an organism that can stimulate the immunity without giving you the disease.
Yeah.
So it can be a dead bacteria. It can be part of a virus. And we talk about antigens, which are the critical proteins, which are considered foreign and which your body and mine would make a defensive immune response against.
So these aren't really vaccines, are they? Not really.
They're not vaccines. It's gene therapy. We're injecting genetic material into people and letting that go haywire to basically every cell in the body, so it will make spike protein, which is the antigen that you want to get protection against. But of course, and we move on to this slide, and you can see exactly what happens. That if you've got cells in the body producing a foreign protein, what's going to happen? The body's going to say, wow, we're going to get rid of this. And so you make very effective T cells, which kill not just the spike protein, which is sticking out of the cell, but the whole cell gets killed. It's like an autoimmune disease. So what you actually get is a persistence of this antigen being produced. Not only is it present in so many of the cells, but they keep producing it. We know the spike protein is regularly found in individuals who have been vaccinated for at least 2 years, almost certainly a lot longer, but a long time. And it does two basic things. It provides a foreign target for the effector T cells that normally would protect you against an infection or cancer cells, but now it's actually acting against your own cells because your own cells are starting to look foreign by having a spike protein on its surface. And the other thing that happens is you get, because of the constant antigen present, you get an inflammatory response. Now, inflammation is the body's response to damage. and it can have many different parts, but it's mediated by immune cells. And this inflammation is the basis of what we now call post-COVID vaccine syndrome. It's a variant very similar to long COVID, and again, I think in a slide or two's time, we'll talk a bit about that. We could go on with the other aspects of genetic damage. I know you and I last night were talking about genetic distortion and ribosomal slippage, and amyloid and causing dementia, but it takes a long while to sort of explain all of those things, so we won't go into that in any great detail now.
Well, I've heard a rumour you're writing a paper on this at the moment, Robert.
Yeah, well, that's a rumour I've heard too.
So, when that's done, maybe we should do a separate video on that.
I'd love to do. I'd love to talk to you in detail about what I call the flagship of COVID, which is post-COVID vaccine syndrome. And you'll be blown away you've seen the slides, but people will be blown away when they see the latest data on this, just to see what a big problem for our community this is. I see these people in my clinic now, and it just breaks your heart to see they've been sitting around for 2 or 3 years, and no one even believes them. There are court cases, and you have these guys who are supposed to be on a TARGI and all these other authoritative bodies, and they don't even know this condition exists, and it's present in possibly 10% of the people who have been vaccinated. That many.
Yeah. And you took me to one of your clinics. I was able to meet some of these patients and,
yes, you did.
Learn about their absolutely genuine physical suffering.
Yeah. Well, I'm just commenting on a case coming up before a tribunal at the moment, without going into any detail, of course. And this guy just denies that the problem exists, and he's a well-known person. So it's very.
And again, this goes against the fundamental axioms of healthcare. I mean, we trained up. We were involved in teaching nurse practitioners, and we said something like 80% of what you get, the information comes from what your patient tells you.
Oh, absolutely.
You might do a bit of a physical exam that gives you a bit of extra information and a few blood tests, but basically you listen to your patient. And the famous McCaffrey saying about pain, pain is what the patient says it is, existing when they say it does. We should be, if the patient is describing a symptom to us, our duty, surely as healthcare providers, is to listen to them and believe them. How much more fundamental can it get? And yet this is being completely reversed in the current situation. It's an abdication of the principles of nursing and medicine, as far as I can see.
I would get 2 or 3 emails a day from people all around the world who have got these sort of problems. It breaks my heart. I mean, there's a chap coming out from Canada, and he says one of the main reasons he's coming here is he can't find anyone in Canada to look after his post-COVID vaccine syndrome. And while he's here, could he come and see me? Now, I mean, it's crazy. I'm semi-retired. I only see a few patients now, so I can't see them all. And need more doctors who can pay attention. It's interesting. We had a inquiry back in 23, I think it was, looking at post long COVID. It was called, but it was the ongoing damage from the infection. The political inquiry refused to include any of the related aspects like post-COVID vaccine syndrome. They made no decisions on what was happening and what was going, and just handed $30 million over for research. God only knows where that went. And as a result of that, we had 7 clinics in Australia. They weren't doing much good, but they were at least trying and providing support for patients. There were 7 clinics for long COVID. There are now 2 left. 5 have just gone. That's the outcome of having an inquiry.
So here we're looking at all-cause mortality, Robert. What are these slides showing us?
Okay, we've introduced the topic then of dangers of the vaccine, and most statisticians would say that the best way of assessing the danger of any vaccine is to look at the impact on the all-cause mortality. In other words, we know there's a steady line of mortality within a population, but if something happens and that goes up by 10 or 15%, then generally it's a correlation with whatever's been introduced into that population. Now, the problem with that, which has been widely discussed around the world, has been that you can draw graphs like the one that you can see on the left, which was done by a friend and colleague of mine who is a very excellent statistician on the Australian data. And you'll see that there is a grey area at the top. What you're looking at there is the increasing number of all-cause deaths from a baseline, which is what you would normally expect to see in a particular year. So we're looking over a period of time, over the time from 2021 to 2025.
Yep.
And you can see that there's a overall line, which underneath it a grey area, which has COVID deaths, and underneath that it says non-COVID deaths. So in other words, there is an increase in mortality because people are dying from COVID, but there's a more substantive, say nearly 2/3 of the increase in deaths cannot be accounted for by COVID itself. And you can see the dotted line, which puts the level of vaccines, messenger RNA genetic vaccines given to that community, the Australian community. So you can see that the all-cause deaths are taking off as the vaccine rollout program begins. Now, the big problem has been that up till now you can only say that's an association. You can't prove that either the grey area, the grey area does represent the COVID deaths, but you can't say that the red area, the pink area, is caused by the vaccines because it's an association. Quite an extraordinary guy in Japan, if we move to the right-hand graph, a couple of months ago, looked at 21 million people in Japan, looking at those who'd been vaccinated and those that hadn't, and looked at the mortality rate after vaccination in that 21 million. I had heard that he had 300 volunteers going through this database trying to sort it all out.
Wow.
Now, it's an amazing effort, but it is the first time that instead of just having a general increase in all-cause mortality with an association, here you're actually looking at the increase in mortality of people who were vaccinated. Now, the bottom line you can see is the all-cause mortality in the people who were not vaccinated with messenger RNA vaccines. And the dotted line above, which peaks about, it says 90 to 120 days, 3 or 4 months after being vaccinated, that is the mortality that occurs in the vaccinated group. So what makes this a very important study? And look, it's an early study. It's going through the publication records at the moment, but I know an American has taken the basic data and analysed it himself and come up with the same outcome. So it's pretty solid stuff, but you know, we're all waiting for it to appear in the bona fide press, although I suspect most of the journals wouldn't want to publish it. But
the excess deaths in Australia, we can't attribute them to COVID vaccines. We can say there's a temporal correlation.
It's associated with, and we can't think of any other cause, but we can't prove it.
But in Japan, there's evidence that there is a causal correlation between the vaccines and the excess deaths.
You're only looking at vaccinated versus unvaccinated people. And the increase that you can see in all-cause mortality is only seen in the vaccinated group.
Yeah.
And by 5 or 6 months, it's back down to the non-vaccinated number of individuals.
And if that was true in Japan, it may well be true in Australia.
Well, there's now been a similar study done by another statistician in Australia that is not quite as good as this, but very similar, saying exactly the same thing. And I understand that Czechoslovakian data has been in the last few weeks analysed, also showing vaccinated versus non-vaccinated. So, this is what we're seeing now. All the hens are coming to roost. We're seeing more and more of the data, the good data coming out.
And of course, in the United Kingdom, the vaccinated versus unvaccinated data, they refused to release that just last week.
Isn't that appalling?
The government have refused to release that data.
How could you send a more definite message that there's something here we don't want you to see?
We've got statisticians just waiting for that data, and the government won't release it.
Yeah.
And we know it can be anonymized. We know there's ways to do that. There's no risk of the claim confidentiality, but it's simply not the case. It can be anonymized data.
Well, but you saw their official explanation. It might cause anger or anxiety or something like that. Well, my word, I'm sure there'll be a lot of angry people if they
I can understand it might cause anger if people realised it had killed their husband or their wife or their mother or their father or their son or their daughter. That's kind of understandable, isn't it?
But, it is. But don't you think they're going to think that anyway when they just say, we're not going to give you the data because it might upset you?
I know. It's like Brave New World, isn't it? You just keep the population on soma so they're nice and quiet and placid and manageable. Yeah. It's just outrageous.
It doesn't say much for their respect of the intelligence of the population.
No. But good that Japan and Czechoslovakia and a few other countries, that data's coming to light.
Yeah.
This is going to come to light, Robert. I just hope it's in our lifetimes.
Certainly hope. Well, it's starting to, John. It's starting to.
Yeah, there is hope. The blood scandal in the UK took 20 years, didn't it, to come to fruition before there was an apology in Parliament.
You actually got one, did you? Yeah.
Yeah, eventually, people infected with HIV and hepatitis B.
What happens in this country is that if you sit there barefaced and lie on television, you get promoted to major jobs around the country. It's beyond imagination.
Yeah, it really is. Right, so well done to the Japanese. Not so well done to the Australians and the Brits.
Well, that's true.
Yep.
Now, the next, as I said, there were 5 themes that I put in this talk.
Yep.
The next one has always been one of my favourites, and that is how effective is drug therapy for COVID? And if we can go on to the next slide, John, because it is totally mind-blowing. Now, this is all published data. So let me tell you what we've got here. We're looking at essentially the 2 repurposed drugs that have undergone all more types of comment, the ivermectin and hydroxychloroquine.
Yep.
And then we've got the 3, they're the $1 ones. Then we go the
$1,
dollar. This is US, this is real dollars, US dollars. Paxlovid, molnupiravir and remdesivir. So let's have a look and see each of these drugs in terms of the benefit they give, the number of studies that have been done, the number of patients that have been in those studies. And I love this. They've gone and calculated how much it costs to actually treat a person and how much it costs to save a life using on the database that exists. So let's have a look. Let's start at the bottom. My unfavourite, which is remdesivir. What a joke that drug was. I can remember Tony Fauci standing up, my old mate, standing up on television saying, this is a fantastic breakthrough. We've got this antiviral drug and people were getting out of hospital 2 days earlier. That was the best data that ever came out for remdesivir before it started screwing up people's kidneys. Now, let's have a look. The benefit in terms of percentage is -2. In other words, you're worse off having remdesivir than not having it at all. The number of studies to get -2 is 82. 82 studies. And the number of patients is 200,000. 200,000 patients have been subjected to this poison. And then the amount of money per course that you're getting to get a -2% benefit in US dollars is 3,100. And the amount of money, and I'm not sure how they get this last figure because it doesn't seem to be saving a lot of lives, but they've said 1.6 million US dollars to save a life. Now let's go up to the next one. It goes from terrible to worse to worst. Molnupiravir. we all waited on that fantastic study done in England where they looked at 20,000 people. I don't think, do you use molnupiravir at all in England now?
I actually don't know, Robert. I'm not as far as I know.
Yeah, because it was a total dud, you know.
Yeah.
And the
They,
benefit,
they certainly were using it for a while, weren't they?
yeah. And remember
Yeah.
that these big studies done on expensive drugs are all paid for and organised by the pharma companies. So you
Yeah.
can guarantee that the so-called randomised controlled trials are very much geared to a positive outcome.
Yeah.
Well, the total benefit for molnupiravir is less than 10%, 9%. 51 studies, 180,000, 700 US dollars per course, 2.4 million to save a life. Now, Paxlovid is probably the best of the three. It actually has a 13% benefit, although the most recent study is fascinating because it's a very large randomised controlled trial done by the favourite group of Pfizer, the company that makes Paxlovid. And they thought this was going to be a winner, and it came out at 0-0 in terms of protection. And so the longer you go, the worse these drugs have become. And yet there's been 84 studies, carefully controlled by the company, 170,000 patients, costing 1,400 US dollars per course, and 1.9 million to save a life. Now let's go to the good old cheapies, ivermectin and hydroxychloroquine. Now, you'll notice with the hydroxychloroquine, the overall benefit is 28%. Well, it's a lot better than Paxlovid or molnupiravir. But the interesting thing is that includes those terrible studies, which were really very dodgy, where they were using it in seriously ill patients, some of them in intensive care units.
Yeah, giving it way too late.
Way too late. If
Yeah.
you just concentrate on the early studies, which is the way you... I can promise you that Paxlovid, molnupiravir, they were all done in very early studies.
Yeah.
Much earlier than hydroxychloroquine, even the early hydroxychloroquine studies. But if you you've got a 66% benefit in 424 studies, 590,000 patients studied, and the cost per course is $1, and the cost to save a life is $26. I mean, that is stunning. And I'm the first to agree that some of these studies, you could do better. They're not great studies, but many of them are randomised controlled trials. It's the massive amount of data. You can't say they're all dodgy because they're not.
And hydroxychloroquine's a drug you've been prescribing for decades, Robert, isn't it?
Well, I think every doctor has.
You particularly in immunology have been prescribing.
It's my drug of choice for lupus and rheumatoid and a whole range of other inflammatory joint diseases, sarcoidosis, a whole lot of things.
Yeah.
Ivermectin has a 60. It's the data is so clear. 60% benefit. 106 studies, 220,000 patients, $1, and again $26 to save a life. Now that should be put in the front of every doctor seeing patients. They should have that table so they can make a decision as to what treatment they want to use.
I think I could work out which one I would want, Robert.
Well, I know what I take and I know what I prescribe. I can promise you.
Yeah.
We still have doctors in Australia who have not worked for 4 years because they wrote 20 prescriptions for ivermectin when it was totally legal to do so.
Yeah.
Totally legal.
Yeah.
It's beyond imagination, the idiots that seem to bureaucrats that sit there and do the political whim. I mean, it's amoral. It's terribly amoral.
And you know how to prescribe hydroxychloroquine safely, and ivermectin is noted as
a pen and a bit of paper. It says prescription.
Yeah.
It's really very easy.
Yeah, but I mean, you know the safe dose. You know how to avoid the side effects. You know how to monitor treatment. This is all well-known stuff.
Absolutely. I worked out that I had written, as a clinical immunologist in my long career, 50 years, 25,000 prescriptions for hydroxychloroquine. I've had a few, minor symptoms. I've only had one patient that had eye problems, which is what you look for, and that was after something like 5 or 6 years. The only problem was this particular patient worked for the tax office, and I didn't particularly want to upset that particular organisation, but she had a great sense of humour, so I'm still alive.
That's unusual. What kind of dose of hydroxychloroquine would you normally be prescribing, Robert?
What for COVID?
So, no, for for immunology conditions and for COVID.
I tend to use just one 200 milligram tablet.
Right.
You can use two.
A day.
With one tablet, the side effects are very, very few.
Yeah.
Maybe some people get a headache, a bit of a skin rash. But in some patients, you use up to two. I would never use more than 2 tablets a day.
Yeah.
If you're even with treating COVID, you only use a couple of tablets a day for 5 days. So you're not going to run into eye problems, which generally take 10 years to come.
Yeah, I mean, we can't tell people what to do, but when you got COVID, you took it.
Oh no, I took ivermectin, but I took both. I took ivermectin and hydroxychloroquine, and I was back working the next day.
Well, you came to visit me shortly afterwards, and I didn't get it from
you. That's right, you didn't get it, did you?
No. So you just took hydroxychloroquine 200 milligrams a day for a few days, and ivermectin 24 milligrams a day for a few days.
24 milligrams a day for 5 days.
Yeah.
With some zinc, and doxycycline.
Okay. Yeah. Right, that's just incredible. So all the designer, what I call the designer drugs, the specific engineered so-called antivirals.
You're looking at those. Paxlovid, I think, makes, from memory, something like $200 million profit per year, and it's a useless drug. It's just crazy.
Yep. Good.
Look, I put these in under the same heading. They're 2 very important studies. The one on the left is a study done which you've probably seen before, John. It's been around. It's a wonderful study. It was done in Peru, and you can see this is back in 2020 when COVID was rife and it was killing a lot of people. And we're looking at excess deaths, which were basically then at that time in that place due to COVID. And you can see that when COVID came, it was rapidly climbing. A lot of people were dying, and they introduced ivermectin. And look at the dramatic fall. This was made available throughout the community. Everyone were getting COVID was being treated with ivermectin. And it basically, the excess deaths dropped down to their baseline level. Now, the only mistake in the country was that they had an election, and the person coming in was persuaded that you've got to stop this nonsense, this ivermectin. And look what happened. It returned immediately back to that high level when they stopped using the ivermectin. So I just think that's such a dramatic picture of how effective this. How many people's lives could have been saved by the broad use of these drugs? Now, the other one is a really important study because it only was published a couple of months ago. It's an outstandingly good prospective randomized controlled trial looking at the use of hydroxychloroquine or chloroquine, which is a very similar drug, in patients, in individuals who were associated with someone with COVID. So you're looking to see if you can protect the husband, the wife, or the child, or someone close by. And it was done by the Oxford group, superbly done. And it was something like a 60 or 70% reduction in infections with a p-value. You can see the p-value. I can't remember the number of noughts, but it's something like
0.00024. So
this incredible study.
It's like 24 chances in 10,000 or something.
10 million or something. It's something.
Yeah.
It's huge. I mean, this was the study that everyone was crying out for. The legacy press, the BBC was saying, where is the randomised controlled trial? Well, here is the randomised control. Well, there were quite a few, but this one is a superb one. This study was done on I can't remember the numbers there up the top. I can't see it, and I can't remember. Was it 20,000 or something?
It doesn't actually give a number on this graphic.
Yeah, I think it's something like 20,000 people. A huge number, right throughout the world. It's across the world. Now, the importance of this study is not only is it a fantastic study showing very clearly how beneficial hydroxychloroquine can be, but what it does, it shows you this study was done at the height of concerns about COVID, when everyone was saying we need a randomised controlled trial.
Yeah.
It took over 800 days for that study to be published. And this is criminal. That any study that was showing these drugs were beneficial either were not looked at, or if they were so good like this one and had to be published, they were delayed for over 800 days. What's that? That's 2.5, 3 years.
Yeah.
Isn't that disgraceful?
How do you describe that?
It's hard to describe. It's hard to describe.
It's beyond incompetence, isn't it, or normal tardiness of publication. It's almost as if someone was deliberately holding the whole process up.
Oh, you wouldn't think that, would you?
Well, no, obviously not. But it's a bit like that.
I think my last slide's very similar for ivermectin, which I think you'll really get a giggle about.
Yeah. The word sinister keeps coming to mind, Robert.
Okay. Now, the next slide is about something that I now call the flagship of COVID.
Yeah.
And that's post-COVID vaccine syndrome. Now, this is a syndrome. It's interesting. If you look at the damages that can be caused by messenger RNA vaccine, there are three waves of damage. There's a wave where you get specific damage of cells and tissues as a result of the T lymphocytes thinking they're treating something foreign, which we talked a little bit about at the beginning of this talk, John.
Yeah, it's a stimulated autoimmunity, really, isn't it?
Yeah, and that wonderful graph done by the Japanese showing the mortality peaking at 3 to 4 months, that really defines that wave, because within that wave you're getting, just recently, I think this week came out, that individuals between 20 and males between 20 to 40 had a highly significant 7-fold increase in heart attacks if they were vaccinated. So all that's really occurring within that frame. Yeah. And then there's the second frame, which begins at 6 months, because we say someone's got post-COVID vaccine syndrome or long COVID if it was infection, which is now really called post-COVID syndrome or post-COVID infection syndrome. So you've got these two syndromes, one after the vaccination, one after the infection. And they are this second wave, which starts at, well, it starts early, but we diagnose it at 3 to 6 months, and then it goes on and on. And then there's the third wave, which is really concerning, and we don't know enough about it yet, and that's genetic damage. Due to either reversal of genetic information, disturbance of the genome, misreading at the ribosomal level, so you can foreign proteins and amyloid being formed, all of those sorts of things that can occur. Now, the interesting thing about post-COVID vaccine syndrome is it is very similar to chronic fatigue syndrome. It's got the same characteristics, probably the same genetics, and it's the characteristic symptom is what I call energy-activated fatigue. If you try to do something, it bounces back on you. It's often associated with brain fog. The brain doesn't quite work. My classic example was a patient I had when I worked at McMaster in Canada. I set up the clinical immunology unit there many years ago, and she was a maths teacher, and she used to get a bus to see me, and I always put her on at the beginning of the clinic, because she always arrived after the clinic, because she'd sit there at the bus stop, and it would say McMaster University on the bus. And by the time she realised it was actually the bus she had to go to catch, the bus had gone. This cognitive dissonance or cognitive defects that these patients have. So we could talk a lot about this, and we'll talk a little bit about the treatment in one of the next slides.
And of course, we don't know how big. I mean, I'm convinced we're in the third wave now. It's not recognised, but we don't know how big the third wave is going to be and how long it's going to last for.
Exactly. We don't know what impact it's going to have on this and perhaps other generations. You're quite right.
Yeah.
Now, this is really also two very important graphs.
Yeah.
On the left, and this has just been published a couple of months ago, these people who tell you the post-COVID vaccine syndrome is rare, this is a graph looking done in Germany, and the people who did this study point out that all the other incidence studies are done by individuals who are underreporting because of high levels. They say it beautifully. They don't say they're cynics or they don't want to report it. They just say they have a high level of sensitivity. And passive reporting is always going to be low. This is a study of a population, 5,000 individuals, adults in Germany. And you'll see that the incidence of what was called long COVID is the same as the incidence of post-vaccine syndrome. Right. Exactly the same, 12% in the 12%. Basically, 1 in 10 people are actually running around with post-vaccine syndrome who have been vaccinated, and 1 in 10 people who have had COVID. Now, these don't go on forever, and particularly the post-COVID ones most of them are much better within a year, although the vaccine ones tend, in my experience, to go much longer. So that's the first point. The first point is that there's no difference in incidence between long COVID and a very similar problem in post-vaccine syndrome. Yeah. Dominant symptom being, as you can see, the first 2 bars after, the second lot of 2 bars, you can see I think it's about 9%, I think.
Yeah, tiredness, fatigue.
It's fatigue. And then you've got the cognitive issues and sleeplessness, etc. But the other very important point to note is the pattern of symptoms is pretty much exactly the same in the long COVID, the post-infection syndrome, as it is in the post-vaccine syndrome. Pretty much exactly the same. Suggesting, as I'm sure is true, that it relates to the persistence of spike protein in the body. Now, on the right-hand side is a graph done by one of my patients following treatment of this syndrome with ivermectin. Now, the way I treat these patients is they must use a visual analog scale. In other words, they take each symptom they've got, they give it a 0 to 10 rating, and then before they start, they do 2 estimations of that symptom. 0 might be fantastic health, 10 means they can't get out of bed. So you've got this severity scale. And as you can see, that once ivermectin began, which was about just to the right of the beginning, after about a week, the symptoms went from an average of around about 7 or 8 down to 2, which was fantastic. For this guy, he said his life has changed.
So now, each bar here is a day, Robert, is it?
I wasn't going to show you this, but I literally pulled out. I've got here seven of my patients who have done really quite good graphs. Most of them don't do very good graphs, so I had to pick the ones that had. But look, this is just my eyeballing of this, and you can see that that same downward slope occurs. Now, of those 7 people, 2 of them did not get better at all, didn't respond. So we're looking at the mean level here. About 60% of them do very well. They may require having an extra dose. They may require taking the ivermectin for weeks, months, and I've got one or two people taking it for a year or so. But if they stop it, the symptoms come back. So my assumption is that we know that ivermectin covers and binds the expression of spike protein in the body. And I think what you're doing is getting in between the spike protein and the immune response. Although data that came out again this week suggests that microclots may be incredibly important in promoting this protracted form of fatigue. And we know it's these little microclots are caused by the spike protein interfering with coagulation at the lining of the small blood vessels. So again, ivermectin, if that's the case, ivermectin interferes with that process because it's a very high binding chemical to the spike protein.
So it looks like in these post-vaccine syndromes, the spike protein is still being produced. The ivermectin can.
Anyone watching this with these sort of problems, go to your doctor and say, just give me a trial. It's such a safe drug.
Yeah.
12 milligrams a day, and give a 1 month trial. You take it after breakfast in the morning, and I can guarantee you that 60% of you will have acceptable, if you got the right diagnosis, acceptable response. That's my experience. But it's you need to talk to. I think you met one or two of my patients, John.
Oh, I did, and they were incredibly grateful. I mean, basically, you're dealing with desperate people.
Yeah, they are.
Who some of whom were transformed.
They look. The first one we did, which you saw, that you've seen the graph of, it's in the book. This guy couldn't stand up. His POTS syndrome was so bad, which is one of the things that goes with this condition.
Horrible.
And he has now finished university. He still takes a small amount of ivermectin 3-4 years later, but he's healthy, well, and finished his university course.
Yeah. So the ivermectin is binding the spike protein that's produced, but it looks like from this that the post-vaccine pathology is caused by the production of spike protein, but the ivermectin is only making inert the spike protein that is produced. It's not stopping the production of it.
I don't think it is. No, I don't think
hypothesis.
It is. Yeah. My view is that almost certainly what it's doing is it's binding and interfering with spike protein, doing either combining with an immune response or activating micro clots. Which float around in the blood and cause all sorts of problems. But my preference is, because of the similarity with chronic fatigue syndrome, my preference is that it's probably the immune issue, but I'm an immunologist, so I've got a little bit of bias.
Yeah. So basically what you're doing is giving them a symptomatic treatment until, hopefully, at some point in the future, that their bodies stop producing this artificial spike protein from the vaccine injury.
And that happens, John, because I can't think of, I'd say probably about 20-30% of the people I've been treating are now completely off ivermectin.
Right.
And the only way you can find out at the moment, because we can't measure spike protein easily in the blood, at least in my country at the moment, is trial and error. And so I get people to sort of slowly try to reduce once they've got maximum improvement. And if they bounce back up again, they go back to the previous dose.
Can you check for spike protein IgM?
Yes, IgM.
Yeah. The sort of the immediately produced immunoglobulin.
Oh, you can if you want to, but no one does.
Right. Okay.
No, the routine laboratories won't. No.
Right.
It's not a problem.
Because that might give you a bit of an indicator of new.
I think we do know that that the total antibody drops as what appears to drop as the spike protein dissipates.
Right. So basically, anyone listening for that, there is hope, but why not treat the symptoms while you're waiting for the pathology to abate?
What I'd say look, doctors have been so brainwashed on this. Take these slides and say that this is what's happening. What have you got to lose?
Yeah, absolutely. A very, very, very safe drug.
I'm not I know Pierre Corey in the States is using similar treatment. He tells me, and I know that there are. I met a chap when I was talking up in Brisbane earlier this week, and he was telling me that he's been treating patients, and they all say they're getting benefit.
Yep. Absolutely.
Well, Now, this is the scary bit. What scares
This
me
is the
most...
potential third wave, isn't it, Robert?
Well, this is the third wave, and I think we're a lot of unanswered questions, a lot of scary
Yeah.
questions. On the left, you can see just looking at a number of batches of messenger RNA, looking at the DNA contamination. They've all got some. This is coming from the mechanism of producing it, from the cells that are making the messenger RNA.
E. coli DNA, yeah.
Yeah, it's coming from the
Yeah.
from the E. coli or whatever bacteria they're using.
Yeah.
In the middle, it's just to remind us that we now know quite clearly that the old adage that certainly we're all taught at university is that the DNA information goes to RNA, goes to protein. So you actually translate the genetic information, the coding, into the structure and function of proteins.
Yeah.
We now know quite clearly that the messenger RNA, which is supposed to be between the DNA and the protein, as you can see on this graph, can actually reverse and put its message back into genomic DNA. And that is scary. It's been found recently in a number of cancers. The expression of spike protein, which can only come from a genetic base, and that, of course, is the messenger RNA that these people have had. There was a very scary one I saw this week where a woman in her 80s had something like 9 messenger RNA vaccines, and I think it was 6 weeks after she had a stable breast cancer, she started getting secondaries in her skin, which I would have thought is pretty uncommon in breast cancer, but I'm not a...
I've never seen it.
I'm unaware of people getting... And this woman started getting all these secondaries in the skin, and they biopsied it, and in the nucleus of the cancer cells and the cytoplasm, so both the inside and the outside parts of the cells, they found spike protein. Now that's really, it's an observation. We can't prove anything from that, but it certainly asks questions that require answers.
Yeah, the central dogma of DNA is changed.
The last third of this particular slide, it's not a very good picture, but it's the best I could do.
Yeah.
You can see a sort of blue staining. It's a pancreatic cancer. A very interesting study from a group that sees a lot of pancreatic cancers. And what they found was that correlating with the period when vaccines were rolled out was a big increase in incidence of pancreatic cancer. Now, other people have described that. But what they found was that in a number of the cancers with pancreas, there was evidence of immune suppression of the response to COVID from the too much vaccination. And when they looked at the cancer, this is a section of the pancreatic cancer, those little brown spots are T regulation cells. These are the suppressor cells that are responsible for turning off immunity. And they found that in the cancers that had the evidence of this vaccine-related presumed vaccine-related immune suppression, survival was only half that of the ones that had not had this same, and it turned out to be the number of vaccinations. If you had 3 or more vaccinations, you lived half as long as the ones who had less than 3 vaccinations.
So this is consistent with the idea of the increased vaccinations down-regulating the immune system, exhibiting cross immunity to reduce resistance to pancreatic cancer.
And this is the first direct evidence that might in fact be exactly what's happening.
That is pretty frightening.
Very frightening.
Yeah.
Now this is, I think, my last slide. I love this slide, John, because it tells a story. Now, I don't know Kylie Wagstaff. I'd love to meet her, and if she ever watches this, she's always welcome to have a cup of tea if she comes from Melbourne to Sydney. Now, I've got to be careful because Monash is where I did my PhD, and I'm not sure if you can take a PhD back, but Monash has been behaving a little bit interestingly, shall we say. Kylie Wagstaff was the woman who first showed that ivermectin killed the virus. She is a world expert on ivermectin and viral illness. And in 2020, I think it was very early in about April, she came out showing this was highly effective. And in fairness to Kylie, she said, look, we need to do proper clinical studies. Well, the university clamped down on her like a ton of bricks. And all of a sudden, nothing was heard, nothing was happening. I love this quote from, we have this newspaper, it's not one of our better ones, but it's called the Sydney Morning Herald. On the 22nd of October 21, so right in the middle of all the scary times, this came out, and the heading was, How a False Science Cure Became Australia's Contribution to the COVID Pandemic. And this was the sort of nonsense that was going on. I actually remember seeing this, and I really felt for Kylie Wagstaff, because she was really being suppressed. And now, what we didn't know is that Kylie was doing the right thing. Yeah. She was doing a little tiny randomised controlled trial of her own. Now, I assume she began that way back in 2020 when she had the handle on this ivermectin. But in the meantime, we suddenly find grants of huge millions of dollars going to Monash University from the government and from Moderna, the company that makes messenger RNA vaccines. And here's a picture of the head of Moderna in Australia and representative of Monash University shaking hands over the world's first mRNA, messenger RNA, university commercial collaboration. And that tree is actually $3 million that went to the university. Now, isn't that interesting? So what should we see? I think it's, is it September? I think, yes, September of this year. Kylie publishes her little randomised controlled trial where she was giving, it was a very small study. I think there was only about 60 or so people, but they were people closely associated with someone who got COVID. And they were given just one capsule of ivermectin, just one.
12 milligrams, presumably.
12 milligrams. It was on a weight basis, but it was average around about 12 milligrams. And guess what? Even in this tiny, weeny study, and it was beautifully done, everything was done correctly, there was a highly significant in with small numbers. There wasn't enough numbers to know if you had less infections like we showed in the hydroxychloroquine study, but it was significantly delayed and it was much shorter. In other words, it was not nearly as severe. So here we are, one ivermectin tablet done by the inventor of, well, the first person who showed ivermectin was very effective, who'd been squashed and controlled for five years, suddenly publishing her little study, which I guess she did on her classmates or the people around her because the numbers were pretty small. I mean, good on you, Kylie. I'm so sorry that it was published in a pretty obscure journal, and probably no one else other than me is going to give you the credit for it. But look what happened in the meantime with her university. I mean, it really is a disgrace, isn't it?
Well, it's always good to see some funding going into academia, Robert.
Yeah, I know.
Oh, dear me. Yeah.
So just to put all of this together, which is, I just picked these out as the issues that I thought that came out of our book that were important. The first is that the genetic vaccines have never, ever been shown to have any advantage over the good old traditional antigen vaccines, which, of course, were used in China. An Australian one was developed, but, of course, was banned in Australia, and it was used in Iran. Iran had the advantage of an Australian vaccine, which is very good. They're no better. And, in fact, the early evidence suggests they're not as good as the Korean study in young boys. And where we're at is this cusp of tolerance. And I say it's the elephant in the room. Something you're not seeing with the antigen vaccines because you control the dose with the antigen vaccines. You can't control the dose with the genetic vaccines. I tried to describe the adverse events, in my view, as three overlapping waves, one due to T-cell attack on foreign protein expressed by many cells.
So that's the myocarditis, the pericarditis.
Myocarditis is a classic, and recently that's been actually shown to be truly autoimmune because there's an overlap, a similarity in sequence of amino acids between the spike protein and some of the cardiac proteins.
Yes.
Which is they're very like rheumatic fever, actually, John.
Yeah.
Where streptococcus cross-reacts with the M protein, I think it is on streptococcus, cross-reacts with cardiac tissue.
You've got a similar shaped molecule on part of the spike protein, and a
yeah.
very similar shaped molecule on part of the heart, myocardium or pericardium.
It attacks the good stuff.
Yeah.
And then there's the systemic inflammation, which is classically the post-COVID vaccine syndrome, characterised by fatigue, brain fog, POTS syndrome. And what they also get is burning feet syndrome due to small fibre neuropathy. Very common.
Horrible symptom. Horrible.
And it correlates with the POTS. I think it's the small fibre nerves are attacked, and it's possibly related to some autoimmune issues.
Yeah, we interviewed a few people on the channel. Brianne Dressing springs to mind, and she's just had, she describes her life as rolling in prickly cactus all the time.
Oh, it's terrible. One of my friends and neighbours, who I think you met actually, she got burning feet, burning hands, and I had another patient last week who also had a burning tongue from the same thing.
Horrible.
And of course, the early studies on dementia are scary, and the early studies on cancer, they're red flags. We can't prove, well, we can only associate at the moment. And we want people to really do more work and wave those red flags and investigate it. I pointed out that the repurposed drugs are better than the expensive antivirals. We'll say no more. I was very keen to talk about post-COVID vaccine syndrome as being of similar nature and equal incidence as the long COVID, which we now call either post-COVID syndrome or post-COVID infection syndrome. 10% of vaccinations are leading to some level of this syndrome. And I tried to point out that in many, if not most of these patients, there is treatment that can be highly effective. And I just wanted to finish with saying what I thought the great danger is as we look to the future. The great danger and the unique aspect of this pandemic compared with every other pandemic we've had in Australia is that we haven't learnt. We have not learnt. We've had a series of government-inspired reports and investigations, and each and every one of them have been disgraceful. The second thing is that my profession, medical profession, is shifting to a government control. We aren't making the decisions at a patient level. That the great strength of the profession has been that we've made decisions with a patient and we've made them on science. And what COVID has done has laid bare probably an evolving phenomenon that's been going on for some time. So that's my 5 points, John.
Doctors aren't allowed to be doctors, and they're not allowed to establish concordance with their patients anymore.
That's true.
Robert, that is such a brilliant summary. Thank you, as always, and we certainly look forward to doing the next paper that you're working on. I wish I had half of your energy, I really do.
Well, you're probably twice mine, John.
If only. And the book, of course.
Well, I tell you one other thing that I don't think I've had a chance to tell you. Oh, yes, I have, because you've written something for it. As you know, and some of the Australian people watching this might know, I've been very impressed by Quadrant, which is it's probably a centre-right sort of journal, which is pretty appropriate for people over the age of 50. But it's very
pretty
good.
Appropriate for anyone who's a clear thinker, yes.
They've published 12 of my articles through the COVID period. And each article's looked at what I saw as issues of the day. And they're putting the 12 together. I've written a prologue and an epilogue, and John's written a very nice introduction, as has Peter McCullough from America. And so Peter and John have written an introduction, and they're bringing this out as a small book before Christmas. I never mind saying nice things about Quadrant, because it's a well-kept secret. It's a terrific journal on a whole range of issues, and it's been incredibly supportive of the truth in COVID. They've got an ex-Prime Minister as the chairman of the board. It's certainly not a dodgy journal. It's a high quality, high class journalistic effort.
Yep. And we'll certainly put links to all of these things. Excellent. Robert, as always, thank you so much on behalf of my audience, but on behalf of the human race, really, for what you're doing. You know, you're bringing things to light that otherwise would be suppressed by who knows which alternative powers. So, as always, thank you so much.
John, as always, it's such a pleasure to talk with you.
Yeah, it's really important stuff. Yeah, thank you.